Thank you. Pleasure to be here, everybody. I'm from Boston, Massachusetts, where we're based. Unfortunately, the talk I'm giving today is one that comes from the more cynical side of the industry. I have been working with cancer patients and in big data of informatics and cancer applications for over 15 years now. And I've come to believe that our belief in this temple of what we call medical evidence is actually quite crumbling beneath our feet. So forgive me for the cynicism about this, but I hope that I at least elucidate some additional points and dimensions of the conversation. I'll preface my talk further by saying that this is a talk which will literally barely scratch the surface. And the reality is that I could give this talk for a whole semester at a university to a graduate class and just barely touch on the levels below the surface. There's hundreds of case studies that one could call upon to show why the medical evidence frameworks that we use are entirely inadequate given the advent of personalized medicine and the increasingly small cohorts of patients we try to serve. I believe that we have multiple challenges to our current sources of medical evidence, and I'm going to go through them a bit in my talk briefly. Just to read them out briefly, there's the difference between efficacy versus effectiveness, the high cost burden of data generation, the inadequacy, dissemination, and complexity. And then hopefully I'll give a bit of a solution for why we think that we can address these now. Sadly, and to my surprise, many people don't quite appreciate that efficacy is not effectiveness. So phase 3 trials are intended to demonstrate efficacy in an idealized setting, typically an academic medical center, especially in the United States, with a highly selected homogeneous population with severe exclusion criteria. Yet we then take that evidence and bring it to the real world and say, well, that drug worked in that idealized environment. Let's now expect that it's going to work and be efficacious and demonstrate effectiveness in the real world. And so I just want to point out here that this is, I think, a fallacy that we all need to be aware of, that the evidence that's generated in that clinical trial environment is not necessarily going to map positively or negatively into the real world. Interestingly, when I was doing research for this, I ran into this fantastic quote from a paper in Value and Health in 2014. A disconnect between outcomes from clinical trials and information needed for clinical practice has been identified in the process of standardization of drugs assessment. This was published in by Schwartz in 1967. That is 50 years ago. Evidence-based medicine, published merely 20 years ago, and knowledge dissemination, 22 years ago, and called for the efficacy to effectiveness gap. Right now, the last sentence is the killer. The need for more systematic assessment of effectiveness is now widely acknowledged. This is November 2014. So my point here is that we're sitting around this table looking at evidence of various forms from clinical trials and then trying to extrapolate it to how it's going to work in the 80% of patients that never would have even seen a clinical trial in the community setting, especially in America. Let me give an example of what this looks like. Here's an example of real-world safety from ibrutinib from a phase 2 CLL trial, I believe, maybe even phase 3. You can see here a bunch of adverse events were reported. If you happen to actually go online and dig into the paper further, you can see there's a whole host of additional serious adverse events which were relegated to the appendix or the supplemental materials online. Now, unfortunately, when this drug was launched, Anthony Motto, a few years later, identified that in his cohort of study of 76 real-world patients, about 20% of these patients experienced atrial fibrillation, many of them severely. This is a dimension which, as you may be able to see from the fine print, is about 4 lines down in the serious adverse events relegated to the supplemental materials. So this is the kind of signal which we're just not picking up in our conventional idealized setting of the academic medical centers and the clinical trial domains. And I think that increasingly we need to learn to use real-world evidence in a continuity of evidence as drugs make it from the clinical research domain into the practical domain. I'm not the first to sit here and show you that the cost of medical evidence generation is at an all-time high. Clearly, there's still a sustainable business model here because we still have unprecedented numbers of trials occurring. Likewise, we're seeing that increasingly biomarkers are being brought into the clinic as a means of boosting the success rates. And you can see that you get from phase 1 to approval, when you include a biomarker, roughly a 3x bump in terms of the success rates of drugs that are met or included with companion diagnostics or biomarkers. This all makes sense. Now, sadly, though, one of the classic cases of such a biomarker, HER2-positive breast cancer cells in 1998 approved, identified that HER2-positive cells had, shockingly, a 20 to 30% response rate to a drug which is supposed to be targeted exactly to that subpopulation. And it was a decade later that Genentech even admitted that about 5,000 patients in the United States received trastuzumab without any clinical benefit, and about 7,000 could derive clinical benefit but are not being treated because of a false negative test result. So further evidence that this is actually quite a shocking system, to think that we actually can rely on these as much as we do, these diagnostics, because they can fall woefully short when brought into the real world. Lastly, and I hate to say this is maybe the pinnacle of my cynicism, so excuse me, this is a paper that was reported in BMJ a few years ago, which compared the eligibility criteria as reported by 52 trial protocols that were performed at a German medical facility and the subsequent 78 publications that came from it. Now, amazingly, the paper identified that the mean number of eligibility criteria was 25, which is quite a long list if we think that these are generalizable results. Furthermore, 100% of the 52 trials failed to, in at least one publication, submit subsequent or report fully the eligibility criteria of their trial. All right, 44 reported modified, 21 added new criteria, which is even more shocking if you think about that. And sadly, about 50% of the total protocols eligibility criteria were actually reported. So my point here is really to say, when we're actually consuming the medical evidence, even through the dissemination approaches we have, we're even seeing a biased view of what that evidence is. So this is actually quite a shocking result when one thinks about this. Now, obviously, the advent of advanced therapeutics and our increasing arsenal of opportunities to treat and engage with cancer is at an unprecedented high and tremendously exciting. But all this is doing is adding to the complexity that must now live inside the head of a physician, an oncologist, a practicing doctor. And not to mention that the pharmacopoeia is at unprecedented levels, but as well there's dimensions of dosing and cycles and toxicities and labels and biosimilars, contraindications, comorbidity, supportive care adherence. All these dimensions need to be brought into bear. And you know, some of the smartest people I know in the world are physicians. I don't know how we can ask human beings to keep all of this in their head, especially when they're treating multiple types of cancer. Likewise, when we add in the advent of circulating tumor DNA, as we've been speaking about earlier this morning, we can see that the real-time monitoring of cancer and the additional dimensionality of characterization now is going to enable whole new precedented forms of treatment of disease, and this simply is untenable to do inside the human mind. So if I haven't made enough of you squirm yet, I'm going to hopefully get down to my point in a second. This is a network that my company generated on multiple myeloma. This network, every node there represents a molecule, a gene or a SNP. It's hard to view. Some of them are actually red circles, which are actually clinical outcome variables. And you can see here that every edge represents a punitive causal relationship of A causing the state of B to exist. And now you can just see that this is a tremendously complex system. And for us to reduce biology to single markers and single dimensions of diagnosis is, I think, actually a bit naive, sadly. And I think that we're slowly learning that, and eventually we're going to learn it even more. So my point is that we could never expect the human mind to follow this, and we need actually to be using big data effectively to advance this. And furthermore, we're never going to be able to personalize it unless we start bringing in the opportunities to bring advanced computation to bear here. So what I suggest is that we really start thinking about real-world registry analysis and how to bring that up to a level of gold standard medical evidence. Registries are typically not considered a tier 1 standard of gold standard evidence. Forming pre-competitive registries by national and international consortia and disease-focused organizations would enable that. Establishing best practice analytical methods and gold standards for how analyses should be performed enables people to actually believe the results that come out of these observational studies. Enabling a fabric of freely available registry-based data commons, which would enable people to share data and access data and let the citizen scientists among the world get access to such data. Likewise, I believe that we can start to begin to enhance the structures and capabilities of transferring real-world clinical data from EMRs into registries for future analysis, and then start to deploy clinical decision support systems that actually can take into account the true complexity of cancer. And as you can see on the right, those are the 5 challenges I noted, and this sort of a plan, while quite vague, I'll admit, is actually, I think, a way of addressing each of these dimensions. Already we are seeing progress. Here's, sorry to say, a bit biased view of American-based efforts on this topic, but folks like Flatiron and CODA and the Orion Information Exchange Network Likewise, the OPN network, as sort of started by Intermountain and Stanford, are examples of data sharing commons that actually are going to enable this sort of study to exist. And the US government has created a registry of patient registries, which also could be a source of additional cataloging of this type of data. I lastly want to share with you just a quick anecdote, if I can, of what we were able to do with this data in a R&D setting in our own company, my own company. We wanted to seek and understand in the context of multiple myeloma whether Velcade alone or Velcade plus immunomodulatory agents were able to, we could distinguish who benefits from the addition of immunomodulatory agents or IMiDs. These drugs are considered to universally benefit patients. You can see on the survival curves on the right that typically those doublet or triplet therapies that involve IMiDs do actually benefit the patients in terms of survival. So we took a registry from the multiple myeloma COMPASS data set and looked at about 265 patients who received either Velcade alone or Velcade with IMiDs. What we're able to do is build one of those punitive causal networks and then actually simulate above that the benefit that one would anticipate whether a patient was treated with Velcade or not Velcade. So what we're able to do here is make now synthetic patients and run hypothetical clinical trials. And of course, as we'd expect, the probability of a patient entering complete response is shifted to the right when one sees Velcade plus the addition of IMiDs into the combination. So this is exactly what one expects as a universal benefit. The reality is, though, is that that benefit is not even. This is a bit of a cartoon, but an example of some of the drivers. We talked about biases in clinical observational data sets. We actually explicitly grab biases sort of by the horns. And you can see here that there are biases in the data, such as patients do not receive IMiDs when they have high creatinine or renal insufficiency. That's a bias introduced by clinical practice and the guidelines, which makes tremendous sense. But that being said, because we're able to factor those in, we can also factor them out. And so our methodology allows us to take these biases and actually bring them into the computational construct and actually address them head on. Furthermore, what we were able to identify is that there's a series of about 20% of patients who, in principle, are receiving IMiDs today, but actually are receiving a tiny fraction of the benefit of the average responder to IMiDs. And it turns out that there's a molecular driver of this, FGFR3 positive cells. And so this was subsequently validated by Celgene. But what this suggests to us is actually that there's a tremendous amount of discovery that we can learn to advance personalized medicine from reliable, real-world, publicly available registry models like the COMPASS registry dataset. And I hope that I've made my point today that current forms of conventional medical evidence really are going to be, I think, reaching the limits of their value. And I think that we need to start complementing those forms of medical evidence with real-world medical registries like this, and then layering on tremendously rich big data technologies like this. Thank you.